just to apprise you of the normal intervals. So you should be knowing some normal intervals, which include the PA interval, the AH interval, and the HV interval. So I'll show you how they are measured and what do they represent. You should be knowing their normal values. So basically what PA interval is, so it's a measurement of the intra-atrial conduction time. So this means that it has to do with the atria. So the P waves, as you can see, that P waves are seen on the surface ECG. So whenever an EP tracing is placed, you always have to look the surface ECG as well. Don't forget to see the surface ECG because they might give you some clue or hint regarding that diagnosis. So please don't forget to see the surface ECG. So P waves are seen on the ECG and the A waves represent the intracardiacs. So the PA interval is a measurement of the conduction from the sinus node, which represents a P wave in the normal healthy hearts, and the conduction time from that P wave to the atria deflection on the his lead or his electrogram. So I'll show you these values on the intracardiacs as well. The AH interval, very common interval, AH and HV are very important interval because if they are deranged, then they might help you in the diagnosis of bradyarrhythmias. So usually a tachyarrhythmias come up, but you never know, bradyarrhythmias can also be seen. So the AV blocks, you have to pick them up with the AH and HV intervals. So I'll discuss this concept further. So what is AH interval? The AH interval is measured from the atrial deflection on the His catheter to the first His deflection. And it is a measurement of the AV node function. How good is an AV node? HV interval is again important interval. It is measured from the His catheter, the proximal His actually, to the onset of the ventricular depolarization, the earliest, wherever you can see the earliest ventricular depolarization, you have to measure from that to that area. And it is the representation of the His Purkinje conduction time. So there are some values. Sometimes we discuss the tachycardias on EPs in millisecond. So they will not give you in beats per minute. They will give you in millisecond. So you have, it's a very simple formula. You can just convert the beats per minute to millisecond and vice versa. So beats per minute, let's take into account example. The formula is 60,000 divided by beats per minute. So if you want to convert the beats per minute to millisecond, so 60,000 divided by 110 is roughly around 545 milliseconds. So you just remember the value 60,000 and divide the value which you want to calculate. So the 110 beats per minute is equal to 545 milliseconds, and 545 milliseconds will be given on your EP tracings. So, but just in case you want to calculate the heart rate, you can divide this. So now let's start with the EP tracing. So EP tracing, usually they will give you probably in black and white. This is a real patient which I have done. So this is color coded, but tune your eyes for the black and white as well. It's very easy to pick colors. So there are some parameters which you can see on your left hand side over here. The HRA, the HRAP, HRAD, HIS, CS, and RV. And this is the surface ECG. So always see these when trying to interpret any pathology. Because if you kind of forget to see, then based on their, because they all represent something. So don't mix them up. Always see the normal. This is a normal, healthy conduction that is going on in a perfectly normal heart. So the aim of this slide is to identify how the catheters are placed, and the leads are also shown. Usually 1 to 2 leads or 3 leads are shown, surface ECG leads. And then obviously the HR, the height right atrium, is the next stop. And after that, the conduction goes down to the his and then into the RV. Coronary sinus is basically a kind of a vein in which we put the catheters. I hope that mostly you have seen the BP studies in your training. So they put a catheter in the coronary sinus. This is very important structure in that case. So, but please don't forget to see the coronary sinus activation, because when they will give you a slide of pathways, for example, a left free wall pathway or a right free wall pathway, and if you do not know which CS signal are you seeing over here, so then you can totally pick the diagnosis wrong. Okay, so I'll discuss in some scenarios further as well. I have some scenarios for you to decipher. Okay, so please again emphasizing CS 7, 8, or 9, 10 represent the proximal CS, means the CS close to the septum, and 1, 2 represents the distal CS close to the left free wall. Usually, this is a normal in Pakistan because you are giving the exams here. So in Pakistan, most of the laboratories, uh, their representation is this way. Okay, but ideally they should give you CS proximal or CS distal. So if they give you proximal distal, don't get confused. It's the same thing. So 9, 10 or proximal, 1, 2 or distal. I hope you get my point. So now let us see how the conduction goes in a normal CS. So the proximal CS will get activated early and the distal CS will get activated late. Okay. So because the septum, definitely the conduction goes to the septum first and down the AV node and ventricles, and then it spreads to the both of the ventricles and then epicardial exit. So the CS 910 should be activated earlier, definitely, as compared to CS 12. So this is a perfectly normal conduction. Okay, his this is a his. Okay, very sharp biphasic deflection will be his. Atria will be a kind of a bizarre, fractionated, and multipolar signals. Okay, so get yourself accustomed to these signals. So don't confuse this his signal, very sharp spike, small, with the atria. Okay, so as you can see, the HRA is activated first, kind of relatively activated first, and then the signals go down. I cannot unfortunately show you an atrial signal, but it was somewhere here. Okay, and then the CS 910 was activated, and then it came down to the RV. So clear, all clear. Any questions over here? Because this is very important. You have to understand how a normal conduction works. Then you can only identify the pathologies. And once again, don't forget to measure these intervals. You cannot measure them, but they will give you, uh, for example, they will tell you that from here to here, it is 600 millisecond. Okay. So this means they will always give you in millisecond and not beats per minute. So you have to convert that 60,000. So if you convert 60,000 to 600, it will be around how much? 100 beats. So it's simple mathematics. Okay. So just remember the formula. Okay, let's move forward. So any questions so far? So now we'll be discussing the intervals. Okay, so this is now a representation of the previous points which I've discussed. So the P interval starts from the P, right from here, onset of the P, anywhere you see the onset of P, and then over the atrial signal is somewhat here. Okay, so it's not unfortunately a very good atrial signal, but you can see some deflection, very small. Okay, so these are the P intervals. The AH intervals from here to here. This is the his. So this is the AH interval. And HV interval is from here to the first onset of the ventricular depolarization. which I think this was the first onset. Okay. So, but don't worry, they will give you intervals if they want you to pick some pathologies like first degree AV block or even Venki back. Third degree AV block usually doesn't help you over here because it's pretty clear. So in case of first degree, prolonged HV interval, or even prolonged PR interval, so they might give you these intervals. I hope it's all clear so far. Okay, so just to show you how conduction system goes, we'll just quickly read this these lines and these diagrams. So from here, the conduction starts. Okay, it makes a P. It goes down over here to the septum in the area of AV node. This is the area of AV node. Okay, so this is PA interval around here, and then AH will be around here, and HV will be around here. So this is just to show you how they are measured. Okay, and you put the catheters. I'll show you in the next slide. So sometimes the conduction always also goes to the other atria as well. So to the from the right to the left atrium to the through Bachman bundles and multiple other things, but we'll not go into detail. This is not important, especially for exam purposes. So this is how the catheters are placed. Okay, so I've marked the catheters. So if you can see the CS catheter, this is a very important catheter. Okay, just this is just to show you how the catheters are placed and how we see the signals. So I have discussed earlier, like look, CS910 is proximal. So this is a spine, this is a haze. Haze is the septal structure. So you see CS910 goes to the left free wall. So the normal conduction, it will spread from here to here, just like in this case. Okay. So I'll show you. Okay. So it will be like this. Okay. And then it will come like this. And then it will spread like this. So this is a normal conduction. I hope it's clear. So this is why CS910 was coming early and CS12 was coming late. Okay, so this is just to show you, I think this is not of any relevance regarding your exam, but just to make your concepts more clear. You can always ask any questions in between if you want, because I want you to understand these concepts, because you have to apply all these in your tachyarrhythmia diagnosis as well. So now let's start with some scenario. So they will probably give you this because every patient with tachycardia will present with palpitation, either syncope. So this will not help you a lot, the history. Age might help you, but definitely usually they are mostly younger people who are having tachycardias. So this might help you, but this will not be quite a lot of help. So now this is your uh, scenario. I have marked some intervals for you as well. And anybody who would like to pitch in and just comment on what is happening and what is the likely diagnosis in this patient. So they'll not give you a lot of slides. They'll probably give you one slide or hardly two, and not more than that. So this will be mostly a spot diagnosis in your case. Anybody, it's a very common exam question. So I think somebody should take it. You can unmute yourself, give a try. Can this be a sinus tachycardia? What do you think? Can this be a sinus tachycardia? Okay, so sorry for the terminology. It is a slow fast, typical AVNRT. So this is a typical AVNRT. So just remember this slide. Please don't forget this slide. This is a very important, very common tachycardia. So this is a typical AVNRT. So why this is a typical AVNRT? Because just remember, any tachycardia in which both in which both the V and A, if they come on time, like they are right exact on time, then this is an AVNRT. Just remember that. So if you can see, these are the V's and these are the A's on the CS. You see? So they are just on time. Even some A's are almost at the start of QRS. So which tachycardia is most likely? It is AVNRT. The reason is because the atrial tachycardia is a long RP tachycardia. So there is a concept of RP tachycardia. So long RP, intermediate RP, and short RP. So anybody who can tell me how do you define a short RP or long RP or an intermediate RP? Anyone who can define that for me? Does this look to be a short RP or a intermediate RP or a long RP? So if you can see, this is the start of R and look at the start of P. So it's just on time. So there's no good time for A to wait. So this means that this is not waiting for this V. So this is independent of this V. And this is a very short RP. So just remember any P which is coming within the QRS has to be an AVNRT. This is a straightforward diagnosis. You do not need to do anything further. Okay. So in exam, this is nothing other than typical AVNRT, or you can just write AVNRT as well. This is the his. You see, this is the his, this is the his, this is the his. So AVNRT. So, okay. So I'll show you how an AVNRT circuit works. AVNRT basically means that this is a circuit over here. Okay. So the normal conduction is through the fast pathway. Okay. And if there is a presence of a slow pathway, okay. So like, for example, if you think there's another pathway over here as well. Okay. So what happens is normal conduction is going like this and downwards towards the ventricles. And if there's a presence of a slow pathway, so what happens is, by any chance, if the fast pathway gets blocked, the conduction goes over the slow pathway, okay, and the conduction goes over the slow pathway, and it comes back to the fast pathway. You understand the point? I hope you get this point.
Yes, sir.
Okay, so don't go into details. This is just to show you how the circuit of AVNRT works. Okay, so this doesn't depend upon A, this doesn't depend upon B. You see, it just depends upon two pathways, slow and fast. So in a typical AVNRT, there is a block in the conduction of the fast pathway. It goes uh, it goes from the slow pathway, comes down and comes retrogradely up to the fast pathway. So over here, what happens is, sorry, I'm not able to find my marker. Just please wait. Okay, sorry, yes. So what happens is that in a typical AVNRT, this is conduction over slow pathway, and this is conduction over the fast pathway. It's kind of vanishing, so just wait, please. I'm sorry for. Okay, so so this is a slow pathway, and over here it goes to the fast pathway. So this is our circuit of AVNRT works. Okay, so now let's move forward. So how do you manage this? So you have to do ablation. So whenever you do ablation, because you have to terminate the, so which pathway would you like to take out in an AVNRT? Slow or fast? What do you think? Anybody? So if the question comes, what is the definite treatment? So what structure will you ablate? So what will be the answer? So it's the slow pathway. Remember, it's the slow pathway. You never ablate the fast pathway. Okay? Always write the slow pathway, because fast pathway is a normal conducting tissue, and the slow pathway doesn't have that properties to conduct very well. So always take out the slow pathway. Now, this patient ablation was done, and this is the intracardiacs for that. So whenever there is an ablation being done, okay, that uh, just remember that, sorry, somehow it is not working properly. So just remember these. You see these wavy lines. So whenever you do ablation, there will be interference, electrical interference. Okay. So sometimes they might give you a very sleek, sharp spike, which will look an artifact, but that is actually the point where you have given the ablation and ablation has started. So whenever you see these kinds of wavy lines and other are perfectly okay, think of ablation being done. Okay, they should give you that the ablation was being done, but in case they do not give, then just remember the artifact which comes and these wavy lines which will show that the ablation is being done. So now what is wrong with this? Is this a not a good ablation? And the reason is, anybody who would like to come? Okay. So the thing is, whenever you see an ablation being done of a typical AVNRT and this happens, the cycle length, look at the cycle length, 240 milliseconds. So this means so you should stop, because these fast beats, if they occur more frequently, then the patient might go into AV block. You see? So you don't want these fast ablation. Okay. So what you want, I'll show you. So this is fast tension rhythm, pretty fast. You should apply stop ablation. You want this. Okay. The same ablation that is being done, but now look at the cycle length. It's pretty slow. So this means you are damaging the slow fibers and not the fast fibers. Okay. So this is around 554 milliseconds. So this is a very healthy, acceptable junction rhythm, slow, which you want in the patient. So this means that now you're doing the right thing. And if you can appreciate that this is still A on V, A on V, like A and B on the same time. And now look at over here. The patient is back into sinus, because this might be that you have damaged the slow fiber so much that now they are not able to conduct, they are dead. So this is the sinus rhythm now. Okay. So you want this slow junction rhythm and not this fast junction rhythm. I hope you get my point. Okay, so this might be one of the complications which can lead to complications. So this might be troublesome. So AVNRT is important. So please clearly understand. I mean, I'm not going into too details, but these are things which are important. But I don't think so. They will give you maneuver because there's no need to do maneuvers, especially at your level. It's pretty straightforward, A on B tachycardia. So if you see this and you do not know what to do, just write AVNRT. This might be the answer they are looking for. So post ablation, what you have to do is you have to do maneuvers. So as I have shown you that the slow pathway and the fast pathway conduction, how they work. So now this was done post ablation. So what we did an extra stim from the atrial extra stim, basically testing from the CS, you see, and this is a spike, this is a spike, this is spike. What early extra stim from the A, and now what happened? So before that, you see there was one-to-one conduction. So if you can see on the left hand side, there was one-to-one conduction. Okay. So uh, can you see my arrow? You can see my arrow. Can you see this red
Yeah.
light, please?
Yeah.
Anybody can tell me?
Yes, sir. We can see.
Okay. So now look at this. This. Okay, good. This A made a V. This made a V. And now when you put in a very early A, this did nothing. Okay. So this get blocked. So if it was a fast pathway that get blocked, so the slow pathway, if it was present, it should have conducted and initiated a tachycardia. So that's what we call an AH jump. I'm not showing you over here, but because it's very far and you see the A came early. So this means that sinus came because it was blocked and now the sinus took over here. So always remember that post ablation, if they are showing you this testing, this means this was not testing to check the conduction down the slow fibers. So this blocked over here, and this means for them to conduct. So this means that you have ablated the slow fibers. So this is a block in the slow portions. I hope you're getting the concepts. I think this is the important concepts which are more than enough, I think, for your exams. Okay. So again, I'll try to show you over here. So what happened is that we were pacing from CS, okay, CS 9, 10. And what was it doing? It was conducting through this fast pathway. And when we put in a premature, there was no conduction from here. And if there was these slow fibers present, it would have conducted from here. Okay. And then it could have come back, but not present, so they didn't conduct from here. So this is how it was being demonstrated. So let's move to the next scenario. So 2 years old boy who showed a very fast heart rate. So this was the intracardiacs of that child. Anybody who would like to comment on this? Okay, this 2 years old child is kind of a hint. Okay, so it's a pretty young child. So which tachycardias can be seen in a young child? What do you think? So what is the differential of an AVNRT? What if somebody asks you what is the other differential of an AVNRT? So what will you write?
Sir, AVRT, atrial tachycardia.
Okay, good. Any other diagnosis? Junctional tachycardia. So junctional tachycardia basically is again in AVNRTs. When you ablate the AVNRTs and you give that isoprenoline, they induce some tachycardias and you get confused whether this is an AVNRT or junctional tachycardia. Okay, so junctional tachycardia, if this scenario come, always think of a differential of junctional tachycardia and not AVNRT, especially with this tracing. So what's the difference of this tracing from the previous one? So now it's again a very, you can say, kind of one-to-one tachycardia, but here you can see over here that in the CS, you can see in the CS, okay, that uh, this is just over the, these A's are just over the uh, V. Okay. Now this again looks like to be an AVNRT. You see, but over here you can see this just right on time, right on time, right on time. But the difference between AVNRT and the Junctional tachycardia is because the AVNRT is a circuit. So it's a re-entrant circuit. There will be a fixed V to A time. But over here you can see there is V to A variation. You can see this variation.
Yes.
Can you see
Yes.
this variation? Look over here, look over here,
Difference.
look over here, and look over here. So there is a variation. Look over here. A has gone too behind, too far behind. And look at over A over here. So A is kind of coming close to the V. So this doesn't happen in AVNRT because AVNRT is a fixed circuit. Remember, AVNRT is a fixed circuit. There will be not so much wobbling. So any tachycardia in which there is a wobbling, then there are two differentials. It can be either atrial tachycardia or junction tachycardia. So atrial tachycardia, as you know, is a long RP tachycardia, but here it doesn't look to be so long, and there is just A on B at the same time, just like AVNRT, but there is a wobbling, and because of that, it is junction tachycardia. Okay, so this is how you differentiate. I think this is good enough. I think the probably they will not ask any other further questions. So they will just ask the finding and likely diagnosis and differentials. So findings is there is A and short RP tachycardia. There is a wobbling present. Okay, and this is a junction tachycardia. The differentials of junction tachycardia is AVNR. So these are the questions they might ask. So this is just to show you that JT can be confused with AVNRT. So always look at the V and always look at the wobbling, means the cycle length variation, and the VA variation. So this means that this is not an AVNRT. There's so many variation, so much variations. So now they will be good enough to give you variations, but you should be prepared for the first as well. So the thing is that now I have marked these intervals the same, and that is for the same intracardics as I have discussed. So now I have marked the intervals for you. You see how much variation is there in these intervals? So this can't happen with AVNRT. So 376 and 404 is a huge variation in EP. So it should be around less than 20 or 15 milliseconds. So it is around 30, probably yes, around 30 milliseconds. So this is a big variation. So, and it varying tachycardia in a young child is too young, then always think of a differential of junction tachycardia. So this was junction tachycardia. So now this is a 23 years old male who had some abnormal ECG, which is not shown to you. So they have done his EP study. This is the intracardiacs. So anybody who can now take this up. So I have given you the concepts. So if you understand the concepts which I've discussed, then you might, this is a very easy diagnosis if you understand how the conduction system works.
There are some more A's and less B's and eccentric atrial activity is there in the coronary sinus RAs.
Concentric.
Sir,
Are you
here
sure about that?
it looks like eccentric, sir. And there is the AV dissociation also.
So let's discuss the eccentric first. So by concentric and eccentric, these terminologies are used. So this simply means concentric means that the conduction is going from the septum retrogradely and then spreading outwards. And eccentric means that anything that is not going towards the septum or proximal CS, and it is early at the distal CS or early at the right free wall. This means it is eccentric. So whenever abnormal ECG is a hint in this question. So abnormal ECG means that this patient was having a pathway, and so didn't show you that CCG because that was a spot diagnosis. So they want you to pick the pathway conduction retrogradely. So this was a case of this is you're right. It is eccentric, and you can see the distal CS. So it's 1, 2 is not showing any signals, but look at 5, 6. So 5, 6 is coming way early than 9, 10, even his as well. You can appreciate that this is totally eccentric. So this means that the left free wall is getting activated early, retrogradely. So what does this mean? And always please don't forget to see the surface ECG. Is it a narrow or is it a broad QRS? So this is a narrow QRS, you see, because sometimes antidromic AVRT presents with a broad QRS, but I hope they will not give you that tough ECGs diagnosis, but always please see the ECG. So you said AV dissociation. So can you still think that this is an AV dissociation with these two complexes? You think it's an AV dissociation? You can see there is a V and there is an A. There is a V and there is an A. So this you are confusing with the A's, but this is actually the V's. These are the V's. Okay, these are the A's. So don't please confuse these V's and these A's. The trick is that the V's usually are just under the V of the surface ECG. Okay, and now look, why is it possible that there are two A's with so fast heart rate and then totally opposite activation? So it is impossible. Okay, so this was basically tachycardia, and it was showing you an antegrade conduction down the AV node. Okay, and this was, you see, this was a his over here somewhere, and then it came down the his and came up back through the atria. So this was a orthodromic AVRT. So this means a left free wall pathway was the culprit in this case. So I hope you can understand the concept. So what was happening is, so if you can see, if this is a CS, okay. So now the tachycardia, there was a narrow complex tachycardia. So remember, whenever there's a narrow complex tachycardia, the conduction will be going down the AV node. Okay. So the conduction will go down the AV node. So antegradely, it will go down the AV node, and retrogradely, in this case, it was coming through the left free wall pathway. This was a pathway which 10 was 256. This means that this area was activated early, which was not possible in case, because if there should be no connection. So there was some connection in the form of pathways. So it came down over here, and retrogradely conducted to the pathway, and then it was activating from that to this area. So this is the eccentric activation you are talking about. And in this case, it was a left free wall, but they might be give you a right free wall as well. So what will happen? Just simply invert this. So right free wall will activate the HRA first. You see? So this means if it had been a right free wall, okay, it if it has been a right free wall, so what would happen? HRA would have get activated earlier. Okay, the HRA would have activated earlier. You see, in this case, the 156 CS was getting activated early. So just remember, in the left free wall, CS 1, 2, 3, 4, or 5, 6 will get activated earlier, and in case of right free wall, the HRA will get activated earlier or faster rate. So they might just give you this and say that patient is having tachycardia. Now interpret this. So they can give you either ways. So give you in milliseconds, or they can just give you this and tell you that patient is having tachycardia. I hope it's clear. The concept is clear. Any issues so
Yes, sir,
far?
I got it. Actually,
You got
HRA deflections confused because which were coincide with the ventricular. So that is why
Yeah.
it looks like evidence, but it is not. You are right, sir.
So don't please, yes, always try to look at the signals. That's what I'm saying. Just you have to remember how our normal conduction works and what's the abnormality here. Then you can interpret. So just please see the normal 3 to 4 EGMs, and then this is a spot diagnosis. So if you see it, just write it straight away. They'll not give you complex. They'll give you straightforward. Okay, but please again I'm saying, don't forget to look at the signals and which catheter are they representing. So this was an orthodromic re-entry tachycardia or AVR. Uh, in this case, this was activated from here to here. Okay, so let's move forward. So now 21 years old and presented with palpitations. Anybody who would like to tell me, and then I'll show you the intracardiacs of this as well. So this patient had a history of exertional palpitations. So this will be your ECG practice as well. So just take few seconds and give your diagnosis. Okay, so look at lead AVR. What do you think? What's the initial deflection like? It is sharp or it is bizarre? And look at lead V6. So any deep S waves in V6 can't be an SVT. It's very unlikely to be an SVT. So as you see, the V6 is present at in the auxiliary, around the auxiliary line. So the V6 is showing negativity. So this means that the focus is around in that apical wall or apical wall of the left ventricle. So is it possible for a normal conduction to get activated from that area? So it's the most far away area. So this young man was having ventricular tachycardia. Okay, the EGMs of that is very simple and straightforward. So this was the EGM. I think you should not take more than 10 seconds to identify. Okay, please don't confuse with other tachycardias. So you can clearly see this is a broad complex tachycardia, and V is definitely way more than the A's. You see, so and with this broadness and this V to A, V more than A, this was a case of ventricular tachycardia. So if you see more V's than A's and a broad complex, then most likely the diagnosis is ventricular tachycardia. And the management, they might ask you simple questions regarding management. So what will you do? Which drugs will you give? Okay, and I think not more than that. So I hope it's clear. So these are mostly a spot diagnosis. These are not tricky. So you just be knowing the catheters, the surface ECG. Don't forget to see whether it's a narrow complex or a broad complex. Look at the surface catheters. So these are the atrial CS7, 8, 9, 10, 1, 2. And these are the RVs and ventricles. Okay, so V more than a ventricular tachycardia. So any questions? I think probably uh, these are few scenarios which might come up. So AVNRT, junctional tachycardia, pre-wall pathways, and ventricular tachycardia. So very high chances that probably two sessions will come from them. But I think if you know how this system works, how the conduction system works, and how the catheters are placed, I think it's pretty easy then. So any questions? If you have in your mind, you're most welcome to ask. Otherwise, we will end the session. I hope all clear. Okay, air jump. So let me show you how is it seen. There was a slide of that block. Okay, so now I'll explain you over here what does this air jump means. So when you start a tachycardia, you try to induce tachycardia, especially AVNRT, you do the same maneuver, just like done over here. So this is an atrial extra stim testing. Okay, so this means that there's a drivetrain of a fixed cycle length, and there is a very early premature atrial extra stim. So the aim of this extra stim is that if there is a slow pathway present, so this because this fast pathway is getting activated from this. So early will definitely block the conduction from the fast pathway. So this will not produce this. So if there is a slow pathway present, so what will happen? Thing is, there will be increase in the AH. So AH will increase. Okay, and you see that this A is coming early, but this will not happen in case of jump because the A should not come early. It is the blockage from the fast pathway and going through the slow pathway, and this slow pathway will produce a hiss, and then it will produce a V, just like this. Okay, this, and then so this will be a conduction through the slow pathway, and this will be a very large AH. So any decrement of 10 millisecond producing more than 50 millisecond from the previous one. So any extra stem of 10 millisecond, like this is a drivetrain of you can say 400 millisecond. Okay, so drivetrain of 400 millisecond, and you are now giving extra stem of 300. Okay, let's for example say, and this 300 is going to the fast path even as well. So now you will try to reduce or shorten this extra stem. So from 300 millisecond, it will go to 290, 280, 270, 260, 250, and 240, and so on. So the aim of this 10 millisecond decrement is we want to block the fast pathway. And whenever the fast pathway is blocked, if there is a slow pathway present, then this will produce a large AH, which we call AH jump, and then this will conduct down the ventricle. Okay, so this means that the conduction is not going to the fast pathway and it is going through the slow pathway. So remember, AH jump is 10 millisecond difference. Any 10 millisecond difference from 300 to 290 to 280 to 270, and with this there is sudden increase in the AH to more than 50 millisecond. Okay, followed by a his and and uh, followed by a his and then V, and then this is called an AH jump. Clear? I'm not sure if it comes up or I have been asked. Any other questions? I wanted to make it pretty easy just because you can understand. I don't want to go into details too much because I think there are probably 2 stations, 3 stations, and they are mostly of a tachyarrhythmia than spot diagnosis. So, and mostly these are pretty straightforward. If you have gone through those EGMs, I think this is just a spot diagnosis. So, any other questions? Okay, so then thank you very much.